To kick things off, we have an introductory keynote, and I have the pleasure of welcoming Rear Admiral Scott Giberson. He is the Assistant U.S. Surgeon General and Commander of Commissioned Corps, the Commissioned Corps for Ebola Response in West Africa. So welcome.
Can you hear me all? Oh, there we go. All right, good. Well, welcome. I just want to bring greetings from the Office of the Surgeon General. Vice Admiral Murthy sends his regards, and he's aware I'm here, so he let me go for the afternoon a little bit. So, this is about GeoIntel and the Ebola response. I'm going to tell you I'm the first person to admit that GeoInt was a little bit of a stretch as far as my knowledge about it, so I'm not an expert. I learned two things. One, I'm not an expert, and the second thing I'll just share with you in a bit. I looked up on the web, actually, the very trusted source of the Wikipedia, and I looked up a definition of geospatial intel, and it said, includes data ranging from the ultraviolet through the microwave portions of the electromagnetic spectrum, as well as information derived from the analysis of little imagery, geospatial data, and information technology. And I kept going and going and going, and I thought, oh my God, I have no idea what that is or what that means. But after I really looked at some of the images and some of the slides, you're all users. And I can tell you right now that I am a user. However, I'm a user of GeoIntel. It is everywhere. It's pervasive across all the things we do, and a lot of the decisions I made during the Ebola response were in fact using the imagery and the GeoInt that we get from our partners. Now we have the NGA. The NGA is represented here. Who's in? There we go, NGA. I use some of their liaisons to us, to the Commissioned Corps and the Department of Health and Human Services, and realized that we have good partners in there, and it contributes to the overall strategy that we had. Now, my responsibility was the overall response commander, so my level of strategy. However, because we're a small uniformed service, which I'll go into in just a bit, I was able to see the very operational level and at the very strategic level, all the way to the White House. So I had visibility at the White House level, and I had visibility on the ground, boots on the ground, and actually volunteering to give blood when I had a chance to help train my officers that were over there. So it's a wide span that as an admiral you generally don't get in the other services, but with our service being a small response, we were able to get both sides of it. So I can tell you how this geospatial intelligence helped me in each of the decisions we made, and how it really translates to, and how it's applied in our response. Now, you have some experts here that do know a lot more about GeoInt than I do, and have the ability to talk more about the response specifically. So a little bit really about our service first, because you say, well, who are these guys? They're the Navy. Well, I'm actually not the Navy. I do wear a naval uniform, but we have specific insignia that's separate for our uniform service. So we're one of the 7 uniformed services. You all know the armed services, the Army, the Navy, Air Force, and the Marines. Hooah. But you also know the non-DoD armed services, which is the Coast Guard. Very few people know that there's a uniformed service of all active duty officers in the Commissioned Corps of the U.S. Public Health Service. We're over 200 years old. We're older than half of the services. And we're not in the DoD, and we're not armed, but we're all active duty and uniformed. Does anybody know the 7th uniformed service? NOAA, that's right, absolutely. So the National Oceanic and Atmospheric Administration in the Department of Commerce. So NOAA is a small Commissioned Corps of about 300 to 400 folks. I don't know how many exactly they have right now, but there's your 7 uniformed services, so now you learn something new about the United States Uniformed Services. We use GeoInt all the time. This is on our webpage. Who are we and where are we? So we have basically 6,700 officers spread around 800 locations worldwide. We're in 32 different countries. We have 11 different health disciplines. And this is a tool we use online. Anybody can access it to get intelligence on where we're at. So each of the different bubbles is a different officer, and each of the colors is a different agency that we belong to. So we assign officers for their duty to be with the FDA or the Indian Health Service or the CDC or the Department of Defense. We're in 9 U.S. departments. There is no other entity, no other uniformed service that's in 9 U.S. departments. So our roots run deep. So in this case, why did we use the Corps? Well, it directly spoke to our mission. Our mission is to protect, promote, and advance the health and safety of the nation. We've had historical success against infectious disease. We had smallpox, we had polio, we had the Spanish flu, all throughout our history. We've dealt with disease and infectious disease specifically. We've discovered different pathogens like cholera. We've had treatment. We've found and discovered and researched for treatment. So it fits in our portfolio very well. Our skill sets are very diverse. Because I said we're in 9 U.S. departments, we draw from expertise in many areas, whether it's research, whether it's direct patient care, whether it's regulatory science. We have an officer that's an expert in something somewhere. We understand the incident management system, the chain of command. All these, for these different reasons, we were a good asset for the White House to choose to use in the Ebola response. We certainly have a volunteer ethos. We had, when people were unsure and in doubt about going to Liberia at the peak of the response, we had about 1,000 officers volunteer in the first 24 hours to go. So they were very responsible in their knowledge of the fact that this is a unique situation where other people are in doubt and scared. We want to volunteer to go. Now, we could tell our officers to go because we could deploy them just like any other service. However, to take people that have expertise and are willing to go quickly, we definitely filtered those down. We had over 5,000 responses in the first week, and that's out of 6,700 officers. So very specific to public health, very specific to public health practice and expertise. We're culturally fluent. We work in all these different agencies. We work amongst the vulnerable and underserved. And we have our civ mil and our mil experiences, whether it's working with the DoD frequently or whether it's working with the civilian side of the house frequently. So our synergy of the U.S. strategy. The U.S. strategy had to deal with Ebola epidemic in West Africa and stopping the spread of disease where it starts, and that's West Africa. It was a top national security priority for the President of the United States. I mentioned our mission already, which fits seamlessly into what the U.S. strategy was: protect the health of the nation. In human security, we think of the DoD, the armed forces. When I think of health security, I hope you all think of the Commissioned Corps in the future. There we stand at attention in front of our Monrovia Medical Unit, which was our tasker for the response. So our timeline, we had the Secretary sign our activation and deployment memo in September. Later in September, the White House said that we would, with USAID support and HHS support, we would deploy our officers to staff a hospital in Monrovia. And it was a DoD-built hospital that we actually helped design and build with them. In October, very early in October, October 2nd, we had an advanced planning team deploy and start the partnering and construction of the facility. And my colleague here, Capt. Mike Schmoyer, who's going to speak to you later, was part of that advanced team. We only had 4 people that deployed as part of the initial advanced planning team into the heart of Monrovia. Our unique mission, just so you all know, we're the only U.S. government entity that actually provided direct patient care. So our officers were touching Ebola patients, were caring for Ebola patients, and they were healthcare workers and responders. Our overall U.S. government response involved many entities. These were 3 of the biggest partners that we had over there. Obviously, the CDC was involved in our partnering. The Department of Defense was a big partner, and us. Now, we fell in line. In other words, our real overseer in the host country was the chief of mission, was the U.S. Embassy in West Africa and Liberia specifically. They had a DART team there. Anybody familiar with USAID infrastructure? The DART's the Disaster Assistance Response Team, and that's the forward deployed folks for USAID, and we worked with them daily to make this mission work. So our Ebola response goals, and this is getting more towards how I use the GEOINT the geospatial intelligence to our advantage and strategically. So how it applied to our goals. Our goals were to ensure force protection and force health protection. That's our officers' health, our deployed entities, our assets abroad. Establish and maintain the hospital. Our task was, in fact, to open up this hospital and to provide care for healthcare responders that may fall ill with Ebola. Bolster international confidence, which is interesting because we had a lot of NGO partners there. How many NGOs? Do we have any NGO partners here? So there's a lot of NGO partners in the field. There was a lot of international responders coming to West Africa. One of our goals was, because our hospital was open, we would bolster that confidence so more responders would come to West Africa and help with the response. And to deliver innovative and resilient, sustained response efforts for the U.S. government. So strategic planning, and here's where we really get into the geospatial intelligence. Interagency coordination. Obviously, we have many partners from many locations, many areas in West Africa. Having them all on the same page with consistent information, with domains that we could all serve and search, for the information, the geospatial information, was very important so that we were all moving in the right direction at the same time with the same information. So consistent information, working with our partners to get it. Force protection, force health protection. This is the security of our officers. So whether it's the location of our site, whether it's the type of security we could provide, whether it's the density of the populations, where we were located and where we were traveling through, those pieces of intelligence really were able to assist in where we selected our sites, how we moved our troops, and when our assets were on the ground, how to make sure it was a secure environment and how to protect health. We also had to know where our officers could go for health care, and I'll show you in some of the slides a little bit later some of the data we used to develop that strategy. Epidemiology, obviously this is a big one. Whenever you track the spread of disease, geospatial intelligence is very important. We were able to identify clusters or outbreaks of infection. We were able to figure out how dense the infection was there in that outbreak. We were able to find out the locations in the country where the outbreaks happened. All these things to help track epidemiology. Anybody from CDC here? So those folks from CDC would be aware that their main mission was to track the epidemiology of disease and disease surveillance. Surveillance and epidemiology information, epidemiological information is very important, and the use of geospatial intelligence is very important and as an asset to them to discuss, to survey as they go along in their response. Communication. Obviously, communication is very important. Different media outlets that we had. Now, it's communication not between ourselves, meaning, the communications we set up to communicate with each other, but the populations. We have populations at large that are in dense areas of the forest and places where there's very rural. We have to have communication outlets and wonder, by looking at the geospatial intelligence, we were able to tell where the communications were more relevant and more apparent for the population. Training and transportation. These sort of went hand in hand. The training, we used our partners, our NGO partners, to train. In order to train, we had to go to different sites. We had to find locations in the rural areas that they had Ebola treatment units. Using the transportation system information that we were able to discover with geospatial intelligence was very important. We also had places that had no roads, no access. If they did have a road, if it was depending on what time of the year, like weather patterns, you would have flooding and the roads would be gone. So there's no way to get to those places. And as I mentioned, weather patterns. It was very important, given what our job was, to take care of healthcare workers, to find healthcare workers, healthcare and healthcare access. Very important to understand the weather patterns. We're dealing with extreme heat, extreme humidity, flooding in the rainy season, meaning our floors of our hospital or our mobile unit were flooding. When you deal with an infectious pathogen and you deal with decontamination, it's very hard when the floors are flooding or the area around you is filled with water. It's also for vector control. So, knowing the weather patterns is important because of the mosquitoes and the malaria in country that's endemic. Longer-term strategies, capacity building, knowing the sites of the density of the populations and things like that is very important. And the transition of the MMU out of Liberia, where we would use the MMU, what is best situated, and what hospitals needed it, needed some of the pieces of the MMU. So using GEOINT daily to get desired outcomes. So what we did was we gathered the data, we met with our partners, assessed the data, analyzed the data, and were able to implement courses of action. We call them COAs. So we were able to implement our COAs based on the intelligence we gathered, and we hoped for the desired output and outcome. So our planning with our partners, as I said, the second step was meeting with our partners and implementing. We had many partners there. We had the Liberian Ministry of Health. They were the host country leaders. They ran the incident management system there. They gathered a lot of this intelligence for us, as well as our own U.S. intelligence that we had and our NGA partners. The U.S. mission, the embassy in Liberia, provided a lot of that as well. Centers for Disease Control, obviously they were tracking the epidemiology, so they were able to provide us with intel as well. We had non-governmental partners, like I said, for training purposes and for taking care of their healthcare workers that were sick with Ebola. They were also our partners, Médecins Sans Frontières, that's MSF, Doctors Without Borders, International Medical Corps, IMC, and the UN Mission on Emergency Ebola Response, which we called UNMIR. So those are some of our non-governmental and international partners in this response. They all provided different intelligence. We had meetings every week, sometimes twice a week, 3 times a week with each of these partners, and we would share some of the information that we could share that was allowable to share. and decide our way forward and our path forward. Of course, the Department of Defense was a big partner for us for logistics purposes, for life support, for the building, for the security of the ETUs, and we work with them on a daily basis. Obviously, NGA is our partners. We had an NGA liaison in our Department of Health and Human Services, and we were able to access some of that data. So this is just a slide from a courtesy of CDC. It just shows you some of the highest numbers of cases per day, new cases per day. Now you think about in the United States, you think about when we had one case, there was a lot of attention paid to that one case. When we had 2 cases, pretty much the entire country was in a tizzy. They had 60 cases per day. Per day. Now, you can see the timeline there, that spike. So what we did was we gathered our intelligence, our incredibly intelligent Advon team, comprised of myself and Captain Schmoyer and 2 others, decided the best time to go would be right at the peak. So when there was about 60 cases a day, we deployed on October 2nd. What you get when that happens, when you analyze the data that way, is an empty airport. So this is the Africa terminal on October 2nd when we deployed. There was 3 people there. It was the 3 of us. And everybody from the behind the counters would come up and say, "Where are you guys going?" And they said, "We're going to Liberia." They said, "Why are you going to Liberia? Everybody's coming out of Liberia." So we didn't use our geospatial intel as well as everybody else did, but it was our purpose to go there and start the MMU. So next slide is just another example of how we could utilize our intelligence. This was I'm looking behind me here. On a bigger slide, you could see some of the hospital facilities that were there and how they were located spatially compared to the laboratories. So you'll see a little cluster of hospitals or ETUs. I think the ETUs are the pluses, the green pluses. And then by the ETUs, there's also a little lab, a little green square. So you could use this to see where we set our ETU camps up and where we are located compared to the laboratories from CDC and from the Department of Defense. You can also see where the healthcare facilities, the H in the blue square, that's the hospital facilities that were already in Liberia. Another slide of intel, just where the hospitals were located, or healthcare facilities. And when I say hospitals, that's not exactly what you'd picture a big hospital here in DC area. These are very, very small, barely adequate health facilities for the most part. Some of our pictures of our partners from the Department of Defense. There's a nice dirt road that may not be there in a month if it's a rainy season, so we wouldn't be able to pass through that. That was a direct line road to our Ebola treatment unit in Bong County, Liberia. And then that was my favorite mode of transportation, the V-22 Osprey from the Department of Defense. That became a very useful asset because that could fly like a plane and land like a helicopter. So it was easy to drop us in where needed. And then the picture on the left there is us dropping down like a helicopter to be unloaded in Bong County. Border surveillance, another use of geospatial intelligence. Very important to know who's crossing the border and where they're crossing the border most frequently. So as they track border crossings in Liberia, you could see where the spread of disease might come in from another country or might exit Liberia into another bordering country like Sierra Leone or Guinea. Another way to use the intelligence is the tracking of the disease, the surveillance. In other words, the density of the disease on the left, red is bad, burgundy is bad. So you could see the changing colors to the right as we made progress in the response. So comparators, comparing one graph and one intelligence piece with another, you could see our progress in the response from February to April of 2015. Once again, another data point, using the mapping techniques that we did in the previous slide. You map out how the response, when we arrived in Liberia, we set up the hospital and it opened in early November. But the knowledge of us being there was that international confidence that was bolstered. So you could see a drop in the number of cases. We had an influx of a tremendous amount of international responders once we opened our health clinic. And we got direct reports from those responders that said, we were waiting for you to open for us to come to Liberia. So that was a bolstering of that confidence. Country-level operational challenges, another way to use the intelligence that we had. You could see an overlay of the lower right section of that slide there. That's the dense forest areas of Guinea. That's a much harder area to deal with because it's a dense forest area. And what you see in red there is the outline of what Sierra Leone looks like as far as size. So Guinea is a very large country. It's larger than the other two countries combined, Sierra Leone and Liberia. It has more entrenched communities, probably because of the topography and the density of the forest. And there's less international support. So we use the mapping and the geospatial intelligence to decide, in a way, how to strategically respond in these situations and to point out the challenges. Almost done here. We have the last couple slides. This is an interesting slide. This is actually humorous and unfortunately has to deal with your tax money. So we sent a flight halfway across the Atlantic and we had to turn them around and return them. This was a real-time satellite flight tracker which I used. There was a point of no return, so to speak, of our flight, and once it reached that point we weren't going to be allowed to turn it back around. We were able to turn it back around and come back home to Atlanta. We had an officer, we had some folks potentially with the flu, and as they were departing, getting sick, now obviously they didn't have Ebola, they were coming from the US going to Liberia, but we had to turn the plane around. So we signed it because I thought that was historic, that we turned the plane around. I actually got to call the pilot mid-flight and tell him to turn the plane around. I felt like a movie theater, movie actor. So when I said in the very beginning we had a process, we gathered the data, we analyzed it, we implemented with our partners, and then we saw the outcome. For us, it was easy reward to see the outcome. I mean, these were saved lives. Now, we were saving the lives of people who were healthcare responders and healthcare workers. So we had a theme, and it was, today I am healed, tomorrow I return to heal others. So these healthcare providers that were survivors in our clinic put their handprint on the wall, and they went back and joined the forces to take care of other people who fell sick with Ebola. So it was very easy to see the reward in the mission that we had. In the silent war against disease, no truce is ever seen. That is part of our Commissioned Corps March. It's our song, much like the Army and the Air Force and the Marines have their songs. We have our songs, and that's never more poignant than it was in this response, that no truce is ever seen. So we are the Commissioned Corps, the U.S. Public Health Service. We do stand ready. However, we stand ready with the assistance of our GEOINT partners. So that's an opening, hopefully, to this panel, and I'm sure they'll have much more intelligent things to say than I, but this is a little bit about our response to West Africa and Ebola. So thank you very much for your time. So am I supposed to take questions, or is it over now? Questions? I can take a couple of questions, the boss said, so. Any questions? Feel free. She has a question. One in the back. Oh, wait, we got one out here. I can't see real good. Oh, okay, there you go, sir. Where would you say we stand now in the fight against Ebola? Well, in Liberia, we're Ebola-free. That's a good question. The question was, where do we stand now with Ebola? In Liberia, obviously, we've been Ebola-free now for how many days?
Since mid-May, sir.
Since mid-May. So we had a couple months on that. Looking good. There may be another case in Ebola in the future. We can't say that it's never going to happen in Liberia again because there's border crossings, there's potential endemic disease there, but we don't know yet. But in Sierra Leone, we're on the track to go to zero. That should be at zero. I can't say when exactly, but it's on the right trajectory. Guinea's a little bit more challenging. I showed some of the intelligence there from Guinea and some of the spatial, geospatial intelligence. It's a denser country. It's with forest. It's a bigger country. The response, there's not many responders, so we're still not quite there yet in Guinea, but once again, I think we're on the right trajectory for going to zero in Guinea as well. Sir?
What did we do right from a GEOINT perspective, and what can we do better next time?
From a GEOINT perspective, I think the awareness of how much information is out there definitely helps us. I think that, and these guys will speak to that a little bit more, but we used pieces of it. But to know, as I'm learning about it now with some of this, what I actually did was using some of that GEOINT information. But if I knew it before, I would probably access more of it and try to seek out more information about it. So I think an awareness for all of our levels of strategy planning and operational levels, I think would probably go a little bit to a lesson learned or observed. That's good. You know, it was an interesting response because normally, and especially from a uniformed service perspective, the non-governmental organizations like, say, MSF, aren't usually we're not always working together in harmony, and you know, there's always different challenges because they've been in country, they're the host country responders, and we come parachuting in, not literally, but parachuting in, and sometimes try to, you know, take over response. This one was a little different. This one worked very well. I think maybe it could have been the camaraderie behind the mission. It was an easy mission to say what was the outcome we needed and desired. I think what we learned from that is that there are things that supersede all political barriers. I mean, you know, this was a response that everybody helped everybody. The NGOs proactively reached out to the uniformed services and the military to help. I think that there was a lot of lessons learned from coordination standpoint. In Liberia, I could speak more specifically because I didn't spend as much time in Sierra Leone or Guinea. But in Liberia, the incident management system worked very well with the host country in the lead. So some of those things were some of the collaboration pieces that we learned. I had a question up here, I believe. Yes, ma'am.
Does the U.S. Public Health Service actually play a role in deciding whether or not to contain versus treat initially?
The strategy came in consultation with the National Security Council. So, I mean, obviously their discussions are a little bit off the record here, but the U.S. Public Health Service Commissioned Corps, because we're embedded in different agencies, some of our officers are actually on some of those committees that decide. So as an entity, the Commissioned Corps of the U.S. Public Health Service, we may not make that decision, but our experts are pieces of those committees that make those decisions. We have people in Office of Global Affairs, which Capt. Schmoyer was a member of Office of Global Affairs. We have people meeting at the White House all the time. We have members of the National Security Council that are commissioned officers. Obviously, some of the highest levels of response at CDC were commissioned officers. And obviously, from the Health and Human Services side, our Surgeon General and myself were able to contribute. Anything else? Yes, sir. History tells us that it's going to happen again, and hopefully we're better prepared. I feel much better prepared than I was before. I mean, it's not something generally as officers or even health-specific officers, healthcare providers, that we train on Ebola and a large-scale response like that. We do train on infectious disease and infectious disease prevention and control, but to actually be thrown into direct patient care in the Ebola units was a little bit different for us as well. So we learned a lot, and it was an incredible experience and very rewarding. All right, well, I thank you very much. Oh, wait, one more question. One last question, sorry. I'm sorry? I am very proud to announce that we suffered 0 casualties. The only thing we had was an incident of kidney stones. All right.
Not
Thank you very
caused by
much.
West Africa.
Thank you.
All right, thank you, Admiral. So we'll go ahead and jump into the panel, and I will introduce our moderator, Melissa Hersh. Sorry about that. To kick things off.
Sure. Thanks, Jen. Well, because we're a little bit of an intimate setting here, the way I thought we would go about it is I wanted to say a few things that are truly my own personal opinion, then queue up conversations for the rest of the panel. And then once there are a bunch of questions, I thought we could take a bunch of them and then bundle those, and then the panel can take them as a grouping, so rather than one at a time. And if there are any questions that anybody has related to acronyms or questions or anything like that as somebody is speaking, please raise your hand. So the way I kind of saw this panel today is that it's about discussing an ongoing discussion about the strategic purview and operational capabilities that the public and private GEOINT communities possess for developing early warning, prevention, and mitigation tools for disasters of any origin. And so we're really taking kind of an all hazards approach here. And disease disruption and disaster happens to be one element of that. And one of the things that I heard, because I had a few minutes that I was able to hear the keynote speakers yesterday, was really that people were talking about what a unique situation this was and that we were pushing the envelope, and by paraphrasing, basically it was said that this is new history, not old history, and we're setting precedent, and we're channeling data, we're not hoarding it. So it's an interesting comment when you talk to people who operate in the public health sphere, just as the Admiral had said, epidemiology and disease surveillance is something that is constant and ongoing, that has ongoing monitoring of data, which is unclassified. But there's often a schism when health professionals have to speak to military or disaster responders because there's a perception that surveillance has a different connotation. I basically wanted to say that, again, from my own personal view, that there's an interesting thing that came out. One, we didn't have a disaster in the US with respect to Ebola. There was no disaster. Despite what the media said and did, it was not a disaster. The other thing is that military commanders and homeland disaster managers, depending on whether or not this is a CONUS or OCONUS event, don't have to become bench scientists, and they don't have to become clinicians. And conversely, you know, scientists don't have to become logistics operators and to become disaster managers. And that's something that I think, and I'd be interested in the way the panel perceives this, but that's something that I think often gets conflated, and we have expectations that each person has to be able to speak the other's language. And there does need to be a common operating picture, which leads me into just the next statement real quickly, and that's the fact that we have disease intelligence, as I said, because that's what public health people do, but we also have what a colleague of mine, Mike Hopmeyer, calls pathint, or pathogen intelligence. So if you're creating a bunch of different type of intelligence, pathint is just one more thing enabling decision makers to make a more informed decision and to engage in thorough strategic planning. So this isn't very sexy stuff. It's stuff that happens all the time. And there's a difference between what is descriptive data, prescriptive data, and evidence-based interventions. And I think we saw a lot of that play out with how Ebola was responded to and how it was reported in the media. So one of the things, just one last thing to say, is that Ron Klain published an article a few weeks ago in the Washington Post basically saying, what are we going to do next? How are we going to be ready? What is the GEOINT? I mean, and so basically I want to ask the audience too, because these are you guys are GEOINT professionals. What is it from your perspective that you think we need to do in advance of the next incident occurring? So that's just something after the panel speaks that I'd be very interested in getting your take on. So now, after my rambling, I'd like to introduce our distinguished panelists. To my left, I have Karen Walsh, who's the CEO of Blue Glass Development, followed by Captain Michael Schmoyer, Deputy Director of Intelligence, Office of Security and Strategic Information, Department of Health and Human Services, followed by Rob Shankman, GIS Manager, U.S. Department of Health and Human Services, and last but not least, Justin Poole, Director, Xperience, Directorate, NGA. And really, everybody's just going to go ahead and have a conversation, and that's really what I'm hoping this will become, is more of an open discussion. So thank you.
Great. Hi, I'm Karen Walsh, and I kind of want to change this a little bit differently and to stop applauding ourselves of the timeline that was just given to us by the Admiral. I think that what we are remiss in understanding is what really was the timeline. And for health epidemiologists, people out there, let's talk about what we know. And back on March 14th, 2014, the Ministry of Health in Guinea reached out to MSF Geneva and said they had a quote unquote mysterious disease and some type of hemorrhagic viral fever that they started seeing. But what was indicative of that was the hiccups, which hiccups are equated to Ebola. And so because MSF has routinely gone out there inside of DRC, South Sudan, Uganda to work on Ebola, they knew immediately something said Ebola. So they chartered a plane, again, NGOs chartered a plane, went down to Gekadu in Guinea, and on the 18th of March, went to the hospitals and went to the health clinics. And sure enough, they brought in test kits and they realized they had had Ebola. Okay, that was March 18th. By the 31st of March, they realized by looking at what was going on inside of the Ghanaian healthcare system that right now they were in an unprecedented event, and that was Ebola. That the outreach, that the number of cases and their locations was something that they could not handle. So on the 1st of April, WHO publicly dismissed MSF's call for action and said that MSF was out there talking too loudly and trying to gain funds for this Ebola epidemic because they started charting the cases, putting it out there, reaching out to the global health community to say something's going on in Guinea. And if any of you are culturally aware, Guinea, Sierra Leone, and Liberia, through the tumultuous time of from the wars in Guinea, in Liberia and Sierra Leone, we had the refugee crisis. So that cross-border area was everyone crossed all the time, family members, what have you. So on the 21st of June, they declared that this was MSF again declaring that they were overwhelmed. They needed help. This was June 21st, that they needed help. And again, WHO said that they were causing undue panic. And this is when the Sierra Leonean government dismissed that there were any cases and Liberia started popping hot. By the end of July, we saw our first 2 US individuals who came down with Ebola, and they were 2 doctors who were supporting the clinics in Liberia from Samaritan's Purse, and they were transported back to the United States. On August 8th, WHO decided that yes, Ebola was a public health concern because over 1,000 people had died, and that was at a 50% death rate. So then, not only was the death rate over 1,000, we now had cases in Nigeria, Senegal, and Mali. And that thought process of what was happening. So we had modeling by the CDC. We had, I can't even imagine how many, if you looked on the timeline of how many maps and graphs were produced, yet no action declared by the US. Finally, on the 2nd of September, MSF, again, an NGO, had to go to the UN Security Council and ask for military intervention. This is the first time that MSF actually reached out to the globe to say, please bring your biohazard teams, please bring containment, we need forensics, we need your disposal kits for the dead. And finally, it was on the 9th of September that we see action from the Obama administration. So during that timeline, what did it take and what data do we need to use to show the world that we are hitting some type of outbreak? Were the maps not good enough? Was the data not compelling enough? What stopped us from giving the funding that was needed to prevent this? And what was that key turning point? And I will leave with that because I think this is a question to the community and the globe writ large of what data is that changes and is that tipping point for action.
Thanks, Karen. Captain Schmoyer?
Good afternoon. I have slides, but if we're going to do the, nope. All right. But we could do the conversation thing too. That works for me too. I'm going to drill down a little bit deeper and a little bit more tactical level than what Admiral Giberson had mentioned. I'm going to pick on one particular aspect of the timeline that my colleague had brought up here as well. And the reason is while my previous office, I was the director of the Office of Pandemics and Emerging Threats, we had been involved with the, attention and whether or not there was a lack of attention also on many sectors for quite some time. Centers for Disease Control and Prevention have been working with the Ministries of Health of the affected nations since December the year before in 2013, trying to work with the Ministries of Health of the other countries that had concerns as far as preparedness and response, working with the World Health Organization and looking at the data that they were using to make the decisions and the determinations as far as the declaration of a public health emergency of international concern. Those types of things we had been involved in. As we are part of the US government, and it was somebody else's nation, of course, what we were really reliant on was that ask for help, and when we were allowed to go do it. And so I'll talk a little bit about that, when the call for help came, when we were told, yes, please go and do something, and then the applications of GEOINT and how it helped us with what we were going to do. Up here in front of you, you have a model of the Monrovia Medical Unit. Admiral Giberson had mentioned it a couple times. That's a picture there. I have done 2 deployments to Liberia. Before both of those deployments, huge consumer of GEOINT. We do have a NGA liaison at the Department of Health and Human Services. I can't tell you what we would have done without that liaison present. Being able to tap into the determination of possible sites for Ebola treatment units, being able to tap in them as far as transportation routes for potential healthcare workers during the rainy season, during the dry season, being able to take into consideration the different healthcare sectors, assets and resources that may or may not be available, and taking into consideration, of course, that it was changing not only on a weekly basis, not only on a daily basis, but on an hourly basis. So being able to have access to those particular resources through our NGA liaison as well as the rest of the GEOINT community was fundamental. And so that time period that I'm going to focus on right there in the arrows there between September 22nd and November 22nd. On September 16th, we were told we could go. And we said, all right, well, we're ready. We're already prepared. Send us. By the time the travel orders came, funding, and everything else, of course, that's necessary, we didn't get out the door until a little bit later than we wanted. We didn't get out until October 1st. By the time we got to the ground, the Department of Defense, U.S. Air Force had already started building portions of the Monrovia Medical Unit, and we'll talk about that in a second. But again, as far as your timeline, where we're looking at, again, between September 22nd and November 22nd. So our prime directive is the President of the United States on September 16th said, the Ebola epidemic in West Africa and the humanitarian crisis is a top national security priority for the United States. He made that same announcement that the Department of Defense was going to send thousands of soldiers, sailors, and airmen to be able to assist in the response. Their contribution was incredibly important. It involved training healthcare workers. It involved developing and building Ebola treatment units, as well as helping with logistics and other types of needs. The U.S. Department of Defense did not provide clinical care to Ebola patients. The U.S. Public Health Service, as Admiral Giberson had mentioned, was asked to provide that type of support to one particular population, healthcare workers. Healthcare workers that could be from the Ministry of Health, could be from any of the other NGOs that were in country. Samaritan's Purse was mentioned. IMC was mentioned by Admiral Giberson. A lot of the different providers and partners that wanted to go into country were concerned. They were concerned because of the collapse of the healthcare system in Liberia. They weren't sure where they could go if they were at risk for Ebola. And so as we were talking to NGOs, and by we I mean the U.S. government, as the U.S. government was talking to NGOs, some of these conversations, as my colleague just mentioned, this was a need that was established. This was a need the U.S. Public Health Service said we could do, but not on our own. We had to be able to know, where were we going to put this site? We had to know, how are our transportation routes going to be? We had to know, how are we going to be connected to the other ministries' support efforts? How are we going to be connected to the rest of the international community? What was the distance between our proposed sites? We ultimately came up on one, but our proposed sites and NGO healthcare workers that could become our patients. How would we get them to us? How would we get them out of the country if we needed to? And so the U.S. strategy really focused on those 4 goals that you see there. Clicker's a little slow there. The concept of the MMU, again, a system to be able to provide clinical care to healthcare workers. Could be NGOs, could be Ministry of Health, could be U.S. government. Regardless of who it was, we wanted to take them. Partner nations didn't matter. We had folks from Cuba, China, Mexico, a variety of different folks who were there in country, in Liberia, providing support. We wanted to make sure that we could be a bastion of support for them if they needed it. The beginning, looking at what we could do as far as draw up a plan, there was no plan. for an Ebola treatment unit for the US government. We worked with MSF, who did have a plan for ETUs on a smaller scale. So they were looking at beds of about 40 size, or 40 beds per size of an ETU. In addition to that, what they were looking at is typically being in rural areas. This was the first time we had ever had an Ebola outbreak, not only in West Africa, but the first time in a large, major urban center. It was a game changer. Moving on with the Monrovia Medical Unit, we were looking at how can we change doctrine? How can we look at, for example, how we have done clinical care provision for CBRNE victims, chemical, biological, radiological, nuclear, and high-yield explosive? How could we take what we have done as far as doctrine to be able to support patients from these particular situations and change it to something that could support Ebola infection? It was a challenge. It was a challenge. The systems that we had in place for a CBRN type of clinical support wasn't something that was going to be able to be easily deconned. It was a closed environment. How long can you stay in your bathroom if you sprayed bleach to clean it? Imagine being in that situation in a multi-ward hospital that was totally enclosed. And so a lot of these challenges, we had to work with many partners, including our GEOINT partners, to figure out how we can do what we need to do and where we can get to be there. So a couple of the questions that came up as I'm closing up here is, what did we do right? The first thing that we did right is we started reaching out very early on, reaching out to all of our sources throughout the communities, whether it was the GEOINT community or other communities. We started tapping into resources that we had established. It's a lot easier to have those relationships in place rather than wait until you're right of the boom and are exchanging business cards somewhere. So having that LNO, for example, from NGA and LNOs from other organizations was critical to our success. The other thing that we learned is, you know what, we created doctrine here. What can we do to learn from it? And so this model is one of those particular training models that we'll be able to use in the future when we look at what we did and how we could have done it better. How could we have done it faster? Part of our mission was working with the NGOs to figure out how they did it and how they did it so well. And how can we use US government material to duplicate those efforts? The last lesson that I wanted to mention is involve the stakeholders early and often. One of the things that we did try to do very, very closely and very frequently was to be able to involve those stakeholders that are involved in the response as early as possible. So that included the ministries of health, the NGOs that were on the ground, the World Health Organization, the different governments that were providing support in Liberia, Sierra Leone, and Guinea, being able to interact with them. The challenge that we had is bureaucracy is slow. And so we did what we could to be able to look at, and are still looking at lessons learned, to be able to make it faster, better, and more efficient in the future. Thank you.
Thank you, Captain Schmoyer. Rob Shankman?
So I guess they're going to queue up my slides. There we go. All right, we'll skip this slide. Okay, so I'm going to go on to and build on what Captain Schmoyer was talking about, but from the geo part of it, and as well as the intel part. So at HHS, especially in the ASPR department, which is the Assistant Secretary for Preparedness and Response section, we have had an application that we used for situational awareness, and we were right in the middle of transitioning from the old application into the new. So you can see as this is coming out, it's not coming out at the most opportune time. This is, a transition time where we were trying to balance what we were doing and what we were doing well and how to correct that. And here it is, we're in the middle of an Ebola response. So this is the new platform that we had. No one had been used to using it. No one had understood how to use it. And so in the middle of this, we're training everybody on how to access it and how to get to the information. We had talked to people about what the benefits were, because everyone was very confused right there in the middle, that it's more flexible, it's more accessible, it's more agile, it's able to be used with no accounts if we set it up that way, depending on the data and the roles. So we had, prior to the Ebola response, made it possible to give that data out and serve that data out to whoever we want, independent of what platform they're using, independent of what systems they were using. We had made it as open source as possible. We had also transitioned our system from a fully physical system of only 4 servers to now it's 9. I think it's going on 11 or 12 different virtual servers. So we've made it expandable and flexible as well as more accessible. So this aided in our ability to get that information to the folks, not only at the MMU if they needed it, but also to our senior leadership for decision making. And you'll see why and what they were doing with it here in a couple slides. So where did it go? There we go. So we set up our data in roles. These are the services and the folders they go in. We set up, I skipped it. So the second slide that's there in the middle, we set up the different roles, and we actually created a role strictly for Ebola so that we could put everybody in that list that needed it, and they would have access to all the Ebola data that we had. And then we were generating maps and different layers, and this is the current 3 months production. So you can see what we've been doing in the past 3 months. But what we were doing was tracking the teams, and I pulled this up, I guess, yesterday. So we only had 2 teams deployed, but we can track all of our teams every 5 minutes that they're actually anywhere from rostering all the way up through demobilization. So essentially from when they report to the airport as a team to when they land back at their airport at their home station. These trackers will come up whenever they go into that status mode, and they will stay on throughout their total deployment. So when we had teams that were at the MMU, those points were showing up in West Africa, and you could literally click on that point. It would tell you how many persons of what category they were in. So we had talked earlier about, that the Admiral had shown you that there were different teams, and he could show them on his map. That same data is being relayed over here. So not only are the PHS officers able to see where their officers are, our senior leadership can pull up this team deployment slide or this actual application and determine where the teams are. We also have data on which teams have not yet been deployed and who's available on those teams. So they can now start leaning forward on that and determine which teams need to get pulled back and demobilized and which is the next one that's going to be out the door. And if there are any shortfalls on that, we have that information as well. So this is how they pull up the information and look at that. In our application itself, it also has all of the weather information. So the ASPR division our mission is mainly, I'm going to say CONUS, but it's CONUS and territories. So this is our focus, and so we keep the data there, but we also have data that's global, so we can go as far national as we need to go. We can overlay multiple data layers. So this is all available to our senior leadership as well as our analysts, which makes it easier for us to convey the message that we need to convey. We can actually take this, draw notes and messages on it, and then pass a link directly to somebody else via an email. They just open up the link and it opens up the map with all the notes and messages that are on there. So it makes it easy to pass information through. And then we can overlay our hospitals. So here's where it starts to get interesting for us is these were the storms that were just passing through 2 days ago in Upper Michigan, and we can overlay the hospitals. Now inside this hospital database is also all of the bed capacity by type. So we'll know anything from pediatric ICUs to operating rooms to any kind of other type of room you need. And we have it by like that. Let's see. All right, so this is going to scroll through, or it should scroll through. These maps are the confirmed possible and deceased cases of Ebola patients in the United States. This is one map every 10 days. We actually produced 2 maps a day, so I'm only giving you the short version. But you can see how the maps were coming in. This was passed on to senior leadership in their brief. They would see where the deceased patients were and the patients that came in as they flowed through. So you understand how the spatial location of this information was conveyed to our senior leadership as well. It should be almost done. Yep. All right. And then everything that we have is linked off of our portal page. So we've made it very simple and easy for all of our analysts, leadership, and everybody to get to this portal page, start there, launch from there, and get all the information. So we've tried to tie the geospatial piece of it to the intel piece, give everybody access all at once from one location, and be able to provide that to everybody. It's accessible not only internally to our HHS staff, but all of the services that we have that run behind the scenes that power that application are also available to external, both federal and non-federal, the NGOs. So we push that and publish that out. I think that's my last slide. Yeah.
Thanks, Rob. Justin Poole?
You don't need that.
Great. Yeah, hi, I'm Justin Poole. I'm the director of the Xperience Directorate at the National Geospatial Intelligence Agency. And after listening to my esteemed colleagues on the panel, I'm going to alter my remarks a little bit and try to tell you about the saga of an intelligence agency, one of the big 5 intelligence agencies, NGA, that was really willing and able to help in this situation. Because I'm a cartographer from way back, 24 years with the agency, and the capabilities that NGA has as the premier GEOINT organization in the IC and as a combat support agency, we knew that we could bring a lot to bear in this situation. It's interesting, and the challenge being is we don't operate in the open as an intelligence agency, but as a combat support agency with boots on the ground, and in fact we had one of our own analysts in Monrovia supporting the military on the ground, we were able to provide intelligence and GEOINT information on the classified networks as we were ramping up through the timeline that you saw. But if you've heard Director Cardillo talk, and if you're someone like me who knows the power of GEOINT based on my background and others I work with, getting this information onto the WWW World Wide Web for anyone to have access to without having to have user IDs or passwords or common access cards or tokens or PKI certificates was the challenge that we were facing. And but we were ready to take the task on, and with our director's push to move to the open, we needed to find a way to do that. Luckily for us, our mission varies at NGA, and we have, through lead federal agency request authorities are able to support things like, hurricane disasters if FEMA needs our support. So we have a lot of tradecraft, a lot of process, a lot of very mature processes to support this kind of rapid turnaround of our geospatial intelligence, service enabling it, providing the right types of data. And so what we wanted to do was find a way to bring that to bear and provide it on the WWW. So really the challenge for us was the platform to do that, and so we did have some things in our kit bag that we could bring to bear. We actually used one of our GEOINT partners' capabilities, ESRI's ArcGeoS Online, and we're able to spin up a web presence on the WWW on October 23rd of 2014, and that was the first time that an intelligence agency was able to provide its information on the WWW to basically the general public. We were very careful and methodical about how we went about doing that because we have to stay within the authorities that we have. If you heard Director Cardillo talking, we were able to put probably only 25% of our actual holdings over Liberia and the surrounding countries on the WWW, when in fact a greater percentage of our actual holdings were likely unclassified but caveated in a way or licensed in such a way or acquired through agreements such as bilaterals with other organizations that were very strict about how we use that information. because as an intelligence organization, we have that responsibility. But nevertheless, with the military involved, with our own folks on the ground in Monrovia, most of the types of data that we were getting requests for information for from the ground through feedback was for things that we could very easily provide. Airports, seaports, locations of hospitals. We were able to provide rapid turnaround of services mapping the outbreak patterns. Interacting daily with folks on the ground or other non-government organizations who were asking us to do quick turnaround types of support. And the thing that was one of the most gratifying things was to see people throwing their, Digital Globe was very forthcoming with a lot of its data, Google Earth. And I don't want to leave folks out, but people just saying, look, this is important, we need to get this stuff made available. And so using the W capability that we put up was the way to do it, and it was interesting. And so the lessons learned for us, after about 25,000 hits, I believe, during the height of the outbreak, is a fairly significant amount of hits for a W site put up by an intelligence agency. And so it actually took us about almost 2 weeks from we need to do this to having the site put up. And that had to do with the bureaucracy of being an intelligence organization. And that bureaucracy is there for a reason, however, to protect sources and methods and that type of thing. But we were very meticulous about capturing our process, working very closely with one of the best legal organizations in our general counsel at NGA to figure out the best and the least amount of risky ways that we could get this mission accomplished. Looking at how we caveat our information. Why is, you heard Robert Cardello talking earlier today, I believe, about why are things marked FOUO? And oftentimes that has to do with providing the raw data itself. When in fact, often what our folks on the ground or our analysts who are reaching in only need to visualize the information. They don't actually need to download it. And in which case you can provide it as unclassified. Capturing all of these lessons learned, looking at ways to work with the unclassified cloud arena, getting a FedRAMP capability potentially stood up to help store that kind of information, but only provide visualized access to it at the unclassified level. So these were incredibly valuable lessons an intelligence agency like NGA was able to learn so that we are there the next time it happens. And I don't want to get into Nepal, but because of the lessons learned with Ebola, I mentioned about 2 weeks or so to set up the site. We were up and running in less than 24 hours after the earthquake in Nepal with the site to support those efforts. And so we applied those lessons learned. So really, proud of the work that the NGA team did across the board to support Ebola.
Thank you, Justin. So just a few questions that I'd like to ask before we open it up, and that would be, it sort of speaks to some of the things that all of the panelists alluded to, but in terms of the data that's collected on the ground by NGOs, how can there be bidirectional information sharing, and how can the integrity of the data be validated so that that information can also show up online? And who does that validation?
I can start with that, or
go ahead, go right ahead and start.
The only reason is because Admiral Giberson had mentioned that the Ministry of Health was running the Incident Command Center that was in Monrovia. And so this particular Incident Command Center had several working groups, as everyone could imagine, one of which was really focusing on the epidemiological data. And so what they were doing is the NGOs were working in conjunction with the Centers for Disease Control Prevention, but predominantly with the Ministry of Health themselves and being able to provide the data. CDC was there to be able to work as far as assisting with the validation of the data. In addition, the Centers for Disease Control Prevention has a program called the Field Epidemiology Training Program, or FETP. So they had some folks who are graduates of those programs from some of the contiguous countries who were there working with the Ministry of Health in Liberia to be able to validate that data. And so if you remember the one slide where I showed the little arrows where I was going to talk about, we didn't know that that was the peak until several months later because they had to go through that validation. And if folks thought back to actually in October, November, December, the data, there was a big challenge as far as suspected cases and confirmed cases. And so part of that validation, your question is so critical because garbage in, garbage out. If we don't validate that data when we're trying to be able to feed our partners, like say for example, NGA worked with us to develop these ETU books. If we can't give them the correct data to be able to put in those books, the book isn't worth as much. So that's my perspective on that.
From the NGO side, data collection is always going to be tough. And a lot of it is the capacity that you have in your local partners, and also because how are you at one time being action-oriented, same time collecting, same time doing all this stuff. So in the effort to do something, the collection gets missed. And oftentimes data, when it's gleaned, you see that so many questions were improperly understood because of the language barrier, because they're not forthcoming, yes, no, it's cultural divide. I mean, we have a long-term process, and it'll take a long time to make sure that we can handle all of those questions in the future. Because unless there's money in from early on for surveillance, for detection, everything else, we're not going to see that type of results. So if we're not putting money in the preventative side and the training, we're not going to get good data in.
Okay, and this is pretty much an operational panel and not a strategic panel, because one of the things that was obviously alluded to by the Admiral as well is that, the decision window of when to deploy, and both, the three of you actually talked about the timelines. And obviously I used to get the ProMed reports that were coming in early March thinking, wait, somebody should be doing something. But the decision to do something is a very big issue, and choosing to intervene, and obviously our sovereignty issues and economic issues, those come into play very early on. And as we know, we probably could have contained the outbreak in a rural setting, but we did not because we did not choose to act sooner. The issue comes up, and I know, Karen, you do some work on megacities, is just, Justin, this is kind of putting you on the spot, and you don't even have to answer, but something to think about, and then we can turn it over to talk to the audience. But what would have happened if this actually occurred in a megacity? Would NGA have been as likely to turn over the data to the public?
Yeah, I think when you talk about when do we do something, I think you have to look at the scope of responsibilities of who you're asking that question. And so at the highest level, from an intelligence agency perspective, where you're going with putting me on the spot is really not. Two things, American borders or lives are in danger, and support to military operations. And so the fact that we had, and I'll get to the megacity in a second, the fact that we had military going in, we knew we were going to get turned on. And the President's declaration that the captain mentioned solidified that for us, in particular when he talked about the fact that our borders could be penetrated with this epidemic, and you began to see that. And so we were clearly within our lane to begin supporting. I think what you would have seen if it had hit a mega city is just a sense of urgency ratcheted up. I believe the classified information potentially that we were unable to put out on the World Wide Web was not necessarily the information that was needed to support activities surrounding a larger outbreak. Most of the foundational data, the imagery-derived products, the hospital and infrastructure facilities, that type of thing that you would need in spades for a megacity is all unclassified. And so we would have done what was necessary to support the two imperatives I mentioned earlier, American lives and our DoD folks.
One thought to that, as was mentioned, it wasn't just the 3 Western Africa countries that were affected, it also included Nigeria. And so one of the big concerns was the one case in Lagos, which is a megacity. And so one of the hugest concerns that we had at that particular time with that particular case is what happens if this megacity, with this infrastructure that's quite different than Monrovia, was at risk. How would we be able to track that? How would we be able to categorize it? How would we be able to determine, what is the healthcare infrastructure able to handle? Evacuation routes, these types of things. And so it's pretty cool what he's saying, because he's alluding to what could be an astronomical challenge. And who knows how close we could have been with Nigeria. I mean, it was stressful at that particular time, thinking about even just the one case.
But let's go a little bit more than that. Ebola is containable, okay? It's something you can trace. We can do, we can figure out if you have these things. It's not airborne yet that we are discussing yet. But change that now into an avian influenza, MERS, SARS, doesn't matter. And it does get into a megacity. And as much as I would love to agree with you about things are an open source in the infrastructure network, globally, I beg to differ. When we do a lot of mapping exercises around the globe, nations are not willing to tell us where their sewage, water, pump stations are. When we look at we think that we're not open about that. And certainly if you've mapped in global spaces, you recognize that nations don't want to give that information to us because it's just as part of their intelligence network as ours. So now putting that into a megacity where we have something that's not containable, traceable, and now you put into epidemics, I think we do need to talk about containment. Things that we don't want to talk about, but how do you then cut borders? How do you stop transportation networks? What would be a reasonable death count?
Right, when do you let people die?
Mm-hmm.
And just a question that I think, just to go out into the audience as well, is I know that there was a panel on wildlife tracking, and I think it might be going on right now, but because a lot of the diseases that we're seeing are zoonotic in origin, there's a benefit to being able to overlay the migration patterns of animals, whether it's done for the tracking of illicit poaching or organized crime or terrorism, money laundering, it doesn't matter. That is very useful information to enable the appropriate people to have enhanced situational awareness, to understand that this is happening in an area where there is a higher propensity for bushmeat consumption, or where there is already an economic downturn, and so people are going into eating bushmeat much more than they were previously. And that's just something that I think I'd like to ask the audience if anybody here is working on any of the wildlife tracking, and also Justin, if you want to talk about that. And then if anybody has any questions, if you can, just walk up to one of the microphones, and then we can answer the questions after a few of them have been asked already. Thanks. I don't know if you wanted to say anything on that.
Sure, I can speak until see
Yep.
if anyone jumps up. I think basically the capabilities that we have at our disposal translate to any classification level. So plugging in, we don't track the migratory patterns of birds, but somebody does. And that data made available to anyone with a geospatial intelligence background, including our embedded folks or our folks back at the agency, can easily plug that type of data into our services and our tools and our products. And based on the organization asking us the question, we can easily provide analysis on where that's looking, how long it's going to take to get from here to there, that type of information. That's the power of GEOINT right there. And so that's why, to your point earlier, sharing of the information that people have available in a timely manner that an intelligence agency like NGA may not have access to, but if given that information, we can easily provide the analysis that you're talking about.
Okay, I can speak a little bit on that. So HHS actually is already in a partnership with USDA, and we are currently tracking through USDA's data, so through their tables, and all they have are tables, they don't have it spatially. We are plotting all the cases of, what is it, H5N2. So we have that down to the county level, which is the level that they wanted it down to. We had plotted it down to the actual farm level, down to essentially address level, and it was determined that that was not, the comfort level wasn't there. They were afraid that too many people who are supposed to report and then would see that they're reporting at their own location would stop reporting. So now we plotted at the county level, which sort of anonymizes the data, and they also have the migratory patterns. So we can overlay both of those pieces and at least look at migratory, H5N2, is it poultry farms, is it wildlife, what's the correlation, where is it potentially going to go next based on the path of the birds and that type of thing. So we have that, we're working on that with them, so that type of GEOINT is actually...
But that's domestically.
That's domestically, only because that's our scope.
Okay, thank you.
Yep.
Hi, my name is Dave Foster. I'm a retired lieutenant colonel who actually got to serve in Liberia before the Ebola outbreak. And I got to run an operations center for the UN mission in Liberia for their elections during 2011. Data services. So a lot of people will throw up a platform, but that's a platform designed for the organization that built it. Data services, if you can make them, please do. The crisis mapping community at large, you can name all the organizations, have their platforms. As long as you're providing a data service, they can ingest it. And believe me, we've already talked about wanting to give back the U.S. government, because usually the U.S. government takes data and they don't give it back, and that lowers the credibility immensely. So I just encourage folks that are saying they're going to give data, do it as a data service, because there's so many web pages to go to. You can't, it takes forever. You need a whole team just to focus on looking at web pages every day. So it's more of a comment than a question.
But I'll tell you, I agree with you. I personally don't care about tools. The platform, at a trade show, that's probably the wrong thing to say, but I do care about tools. But we're agnostic with respect to the tool of choice or the platform. In fact, if you can go out on your iPad or do it right here and click on the Ebola website that we put up, and it is nothing but data services. And those data services were tailored specifically to RFIs coming from the field. We need this kind of data. We were turning it around as a service as quick as we could. And all the user needed in the field or on their phone was a browser. And so we agree with you completely.
Yeah, and I can just add to that. So the application that we have, it is a portal. It does have web maps associated with it. It also has the gallery available, so you can literally go into the gallery and shop for services, and you do not need to use the predetermined web maps that are pre-configured.
Then the next thing would be to have a centralized U.S. government place. I don't want to have to go to DHHS, NGA, USDA. You just keep saying those organizations. If we're truly invested as a partner, then let's act like partners and collaborate. One location, one source.
That is the challenge.
But one thing about that, we're right now in a very U.S.-centric conversation. That's not applicable to most things overseas, because 105 different NGOs globally came out into Monrovia alone. That's 105 different partners with different ideas, different cultures, different thoughts of U.S. sharing of data. So, we talk about this lovely partnership, but it has to be a global one, and that open source. But I love what you said. If you give data, you better receive that benefit for giving it. And unfortunately, too many of the NGOs who have that granularity out there haven't seen the return back until truly, I would think, this Ebola crisis.
And I just to add to that as well, I've worked on and off for the World Health Organization, and it really needs some serious house cleaning, because if you want to think of a clearinghouse or centralized repository internationally that could host that kind of data, you would hope it would be the World Health Organization, but it's fraught with political infighting and bureaucracy, just like any other government entity and organization. But ideally, it would be something that would be hosted at the international level. And we saw that the G7 just met, basically saying we need to have a white hat battalion rapid reaction force that's multinational, when we all know how well NATO is operating. So I can only imagine what happens when it has to do with health intelligence that shuts down economic borders and international transit and transport.
Hi there. I was wondering if anyone could speak to whether the international health regulations had any impact on the response infrastructure leading up to the Ebola response, or if not, sort of what lessons you learned that could be helpful in setting up that kind of infrastructure.
So the IHRs is actually my old office. So I'm so glad that the $20 I gave you to ask that question paid off. The international health regulations are, for those of you that are not familiar, essentially World Health Organization signature countries sign on to this thing called the IHRs, the International Health Regulations, which in essence means that, hey, if we have a biological incident, we're going to let you know about it. It's really about that simple. And so the challenge is in the 3 affected countries in West Africa, their ability to have reached a level of capacity in association with the international health regulations that would allow them to report the data to the best degree that they could wasn't where they wanted to be. That being said, I'll speak for Liberia just as one example, very sharing with their data. Very sharing to be able to say, hey, this is the situation. As you heard, they were already reaching out to NGOs. They were reaching out to the Centers for Disease Control Prevention folks that were already there, working with them to help analyze the data that they were getting. So even though technically from an IHR perspective, Liberia wasn't quite where they wanted to be, they were still very open with their data. That's the first point. The second point is right about the same time that this was happening, the White House had the Global Health Security Agenda announced. So this was earlier last February. And then right about September 26th specifically, there was a White House meeting. And they were talking about the importance of being able to prevent, detect, and respond to biological threats. And they specifically talked about Ebola. And so the Ministry of Health was there from Liberia talking about this. And part of the agreements that were made on that particular day were, what can we do to be able to support the countries to be able to achieve the international health regulations at the capacity where they want to be by supporting them under the Global Health Security Agenda. In other words, what can we do to unify how the US government is supporting developing laboratory infrastructure, epidemiological surveillance programs, looking at training of professional development and professional development associated with epidemiologists, et cetera. And so the answer to your question is IHRs was a challenge. However, because Liberia was so free, and Guinea and Sierra Leone as well, were so sharing of their data, they realized where their challenges were, and they were very supportive and very able to work with multiple nations, including the United States, the UK, and France, specifically for the 3 affected countries. And now, since September 26th, work is still going on from a variety of different countries throughout the world, not just the United States. But over 42 countries on September 26th last year signed the dotted line and said, you know what, we are going to commit to make a difference so this doesn't happen again. Because it's not just a West Africa challenge, it's a global challenge.
Just one other thing on that too. It's a set of regulations that are, they're not supposed to be just volitional, but there's no enforcement mechanism. So getting countries to pony up that data is not always the easiest thing.
And it's really not. And truth be told, if you go to WHO website, it says roughly about 30% or so of the countries are at the level where they have achieved full capacity under the IHRs. And so please in no way think of it as well, this is a West Africa challenge. It's not. It's a global challenge. And even under the IHRs, the United States still has activities that it's working to make sure that it's at its best capacity that it can be. For example, when Rob was talking about domestic preparedness and response, we were still focusing on what can we do better? What are we going to do if this situation happens? And what can we do next time it comes around to be able to respond and come up with our plans even faster?
Hello. This is more or less like a comment, suggestion. You know, I was actually one of the data preparers for a lot of the Ebola content. And one of the things, we've also done a lot of stuff with mobile apps and, you know, numerous platforms and so on and so forth. But I don't know if you guys are familiar with the USGS, Did You Feel It? So whenever an earthquake happens, you actually have a crowd, you know, folks actually report in and say, yep, I felt it, you know, it did this much, you know, maybe my structure's damaged, you know, so on and so forth. And my idea or thought was, have you guys ever thought about doing something like that for disease? Now, I understand that Africa poses its own separate problems, of course, with technology and stuff, but this day and age, a lot of people have mobile applications, or if you have the big city, you know, outbreak or pandemic, you know, that could be something that'd be a really good and useful tool in the early going, so that you could have that information at your disposal. And of course, you take it for what it's worth. It is crowdsourced, so how much can you, you know, actually take from that? However, you know, with that being said, you know, everyone probably watched Who Wants to Be a Millionaire, but, you know, an astounding statistic there was 86 to 90% of the time the crowd was right. So using that information and going forward, I think that that would be a great tool or something like that that you guys could adopt. However, going beyond domestic, you know, and getting a world influence on that, you know, that's where you would have to try and hit. But do you guys see any kind of value or interest in that?
Actually, I can talk about Indonesia. So USAID had its Stop AI program that worked very, it was determined to ensure that the Indonesian government and healthcare workers would go out and work with farmers who ran chicken farms, because the avian influenza was enormous, and because of its the economic impact throughout Indonesia, it would be catastrophic for most people because it's a source of protein, but it's also a livelihood for so many individuals. So with aid and the Indonesian government, they trained up exactly what you're talking about, health spotters, so that as soon as you reported, you know, and they go around and they were throughout, say, one of the mainland of Jakarta area for Indonesia, and were pre-positioned. And as soon as they spotted it, it went straight to the center, and there what they could do is it was identified as a farm. Then they sent out their team, they blocked off all the roads because avian influenza is easily transmittable, and they went there and they decontaminated everything, killing all the birds, as well as ensuring that nothing was left, so they bleached everything down. Well, the Indonesian government will never tell you that any of that happened because tourism would be affected. Eating chicken is their staple dish. The livelihood of most of the rural farmers would be impacted. GDP. Yep. So while these are amazingly wonderful things, when we talk about even in the US, I mean, our issue right now, look at the price of eggs versus what's really going on. Nobody wants to be that farm that had AI. So while we talk about that wonderful idea of openness, the reality and the damage that it can cause economically, what it can do to the reputation. So what happens if now that county no longer is going to be able to supply chickens to Tyson's? I mean, we never think of the third, fourth, fifth levels, you know, of impact for individuals, but this is what happens when certain data that gets out there and it's not managed and controlled.
There's actually one other layer to that, and I'm mindful that we're running a bit over, but basically there's the misinformation aspect of it too. You know, a lot of the issues related to biological terrorism and whatnot are basically because they are weapons of mass disruption, right? There's the perception, the existential threat that this is going to happen. So if people start posting what they say or they assume is going to be something, or if they put something out there that they want to disrupt an economic, a transit point, or just shut down operations, it would work pretty well. So again, it just goes back to the issue of how do you validate that and how much do you share?
Thank you.
Good afternoon. My name's Dave Bialek. I am the NGA LNO for Health and Human Services that was mentioned several times.
That's our guy.
That's your guy.
Right
I'm
there.
glad you made it here safely.
I think that's all of ours.
I just wanted to comment on a few other things that was kind of hinted at and mentioned. I didn't do this by myself, obviously. I had fantastic reachback support from the National Center for Medical Intelligence, just so people know that we do have an NGA team up there that I would say is experts on the medical intelligence. So when I came into the position not knowing anything of that, I would reach back to them. But more importantly, I want to make sure that people realize that NGA was tracking Ebola also way back in the beginning by this team, trying to locate those ETUs. They're not, as was mentioned before, a hospital you would normally see on imagery. It's very hard to find, very remote in a lot of places. And they were doing that, and they partnered with bigger NGA, our Readiness, Response, and Recovery team, who was able to produce those books, Capt and Schmoyer, that were used quite a bit to kind of capture, if you will, something you can carry. More importantly, we were trying to make our data unclassified. As Justin alluded to, we did that on our www site. But I also want to highlight our partnership with the Multinational Geospatial Co-Production, our MGCP program, which consists of, I believe, around 33 different countries around the world that NGA leads and makes that data available. It's through our partnership with HHS that we were able to quickly make some of that data available, minus that dreaded LIMDIS. Captain Schmoyer, that large map you referred to in Western Africa originally was given to you with LIMDIS on it. It was just a few weeks later that I was able to deliver another one without that LIMDIS. And that's important, as we stated, trying to get data out to those NGOs, unclassified, free to use, free to share. So I think we made a lot of progress with Ebola, and there's more to come. But again, that MGCP partnership was really forged from previous efforts that we did with HHS. So sorry, not a question, just a comment, just to add. I think it was an outstanding response, specifically by the team up at NCMI.
Are you guys able to stay a little bit longer for a few more questions?
Good.
Come on down.
Hi there, I'll try to be quick. I'm Joel Alejandro, I work at the U.S. Naval Research Lab. Just a quick introduction and then 2 questions. Since about 2007, we've been operating in Sierra Leone. In Bo, we have a lab that we operate in conjunction with an NGO doing biosurveillance. We've collected a lot of great data spanning, rooftop boundaries to streets to very detailed health and demographic censuses, obviously PII. In 2013, in the summer, we tried to expand this effort to Monrovia, Liberia, working with Operation Onward Liberty. So we have all this great data. One of the things we've run into is sort of where to push this data out to. Within our own organization, DoD, I've been a bit stovepiped, and it's really gotten nowhere. So at one point, I just released a lot of data on OpenStreetMap. So my question is, 1, where and how do I get this data out to the larger community? And 2, I've sort of asked this question before at a Highfield working group last year, and the answer was map of the world. Is that still the answer? Thank you.
So I can't answer in full your question, but we had a similar challenge with some of your colleagues in Liberia in the mobile lab in Bonn. And so one of the things that they were doing with that particular challenge is working with the United States Agency for International Development, USAID, and the Disaster Assistance Response Team at that point as the lead federal agency for the US government, and sharing the data with them to be able to push to the non-governmental organizations and the rest of the departments and agencies within the US government, and also partner nations who are assisting with the response in Liberia. It was my understanding that the same efforts were to be made in Guinea and Sierra Leone as well. Wasn't involved with those 2 countries, so I'm not sure if it happened. The other thing that the U.S. government did is they ended up having 2 GIS U.S. Army officers who were embedded in that Ministry of Health EOC, Emergency Operations Center, that I mentioned earlier. And so some of the data that they were collecting from the DoD side was being pushed directly to the Ministry of Health in conjunction with USAID, who was sitting there right with them in the Ministry of Health. And so that was the effort to try to address the same challenge that you're putting out. And then the last part of it is contact tracing. The idea of being able to find out an Ebola patient who they have come into contact with, who might potentially be at risk. Similar types of challenges when we were looking at how can we share that type of data when multiple organizations are doing contact tracing. and how is there a unified spot? So don't really have an answer for the country that you're referring to, but for Liberia, those are some of the efforts that they were trying to use to tackle that same challenge.
Yeah, and I can just add quickly to your map of the world point. You know, having been around the intelligence community for a while, we task for, we create, we collect, we analyze data for specific purposes. But with the advent of the type of technology and web capabilities that are out there now, and NGA becoming a service provider that you've heard Robert and Sue talk about, we are looking for anyone who is willing to share their data, not just DoD or IC, but our NSG, ASG partners, or any non-traditional users of GEOINT or producers. And so on each of our websites, whether it's at the highest side or even at the lowest on www, if they are not already there, we are in the process of providing instruction on what it means to provide your data. We had a campaign called Bring Us Your GEOINT, where we would provide you the service enabling instructions. Is it open? Is it tagged? Is it, and there's a laundry list. And if you are willing to do that to your data, we will provide it as a service through one of the avenues is Map of the World. And Map of the World is just the name of a program that is actually about 25 to 35 different services, data services, visualization services that are part of the larger service, GEOINT service construct. So whoever steered you in that direction was taking you in the right path. I'd be happy to chat with you or have one of my folks chat with you offline about how to go about doing that if you can't find it.
So I've been told that we need to wrap up. Thank you for staying late. Thank you to the panelists. Thank you to everybody in the audience as well for all the work that you've been doing, and keep it up. It's obviously well appreciated and much needed. And if these affable, amiable panelists have time after and are around, please feel free to corner them and ask them further questions. Thanks for your time.